Good morning, everyone. With all protocols observed, my task this morning is very simple. My task is to welcome everyone in this meeting. Let me start with our guest speakers. We'd like to welcome you all the way from Germany. You are most welcome to the country of one people. We normally say we are one people because we have got one common thing that is in culture. So that's why this time around we say one Zambia, one nation, and one people. So you are most welcome to Zambia, more specifically to Chreso University. We are a family, and we encourage you to interact and feel free to do your programs with us at Chreso University. To our participants, this is a rare opportunity for all of us. So as our guest speakers are going to do their presentation, let's pay particular attention and contribute. And where we don't understand fully, let's ask questions so that at least by the end of the presentation, we'll go home with something that we have learned from our colleagues from Germany. So with these few words, let me say, ladies and gentlemen, you are most welcome to the meeting. I thank you.
Thank you so very much. So again, the talk for this morning, we are going to have two talks. The first one is on arterial hypertension, the role of 24 hours blood pressure monitoring and pulse wave analysis in something that is very scientific. But in short, we are going to talk about internal medicine, and there are experts to talk in that area, so do not worry. Our second talk will be on tuberculosis awareness. So right now, it is my honor and privilege to call upon Dr. Stephen Kakungu. He is the registrar for Chreso University. Dr. Kakungu, sir.
Good morning, ladies and gentlemen. Good morning. I have a singular honor as registrar to not only welcome you, but also to invite the Vice Chancellor, Professor Dr. Christopher Simonga, to come and give the remarks. Professor Simonga.
Good morning. How are you today? You are happy? That's very good. What an honor and rare privilege to sit in this audience this morning. And what in the olden days was very rare. I remember in my old days at the University of Zambia, it was not a very common thing to get a speaker of that profile, the people that we have today. It's a privilege, so you must count yourselves to be very privileged to listen to the two guest speakers that we have this morning, Professor Michael and Dr. Florian. So thank you, and I also would like to extend our warm welcome as Chreso University to yourselves. But let me also acknowledge the presence of the Chancellor, Pastor Helmut Reuter. He's here. So before we go into the scientific detail of the presentation, I will ask the Chancellor, because he wears two hats. I always say he wears two hats. And when I was asked whether he will speak as a Chancellor or as what, I said, oh, he will speak as a scientist, because he's actually a scientist. So let me welcome, and please join me to welcome the Chancellor, Pastor Reuter, to give a few inspiring remarks, what we as Chreso University aspire to achieve in the portfolio of science. You know, the demand for science, innovation, and finding solutions of many challenges of today's world is certainly important. So, Mr. Chancellor, sir, you are welcome.
Thank you so much. Well, my part is very small, but I want to encourage you today. This is a great opportunity for us to hear, of new ways of doing things. Health is a very evolving kind of science, and we, as Chreso University, have taken it upon ourselves to even go into research to find more ways, how better to serve our nation, Zambia, with health services. I think you're all aware, health is in the news currently. There are all kinds of challenges that we are facing. But thank God for all of you, because you are part of the solution that we have in our nation. And it's my real honor today to welcome our two guests from Germany. We have taken some efforts to form this kind of relationship with the University of Heidelberg, and in fact, the two gentlemen, they are here today. They are working with University of Heidelberg, but are actually from Cologne. Okay, I think both of you, isn't it? And especially the speaker who just comes to follow me, Professor Steffen. He's an expert in NCDs, the 24-hour measurement of our functions, and I think this is what he has been doing, and he will be explaining a little bit more to you. I personally was privileged to have this done on my own body some time ago, and I think it's very exciting for us to have this in Zambia, because I think, as far as I'm aware, no one in Zambia has had that technology apart from ourselves. So we have been testing this at Chreso Ministries, at our clinic there, and I think, as far as NCDs are concerned, this is a growing problem, and we want to be really at the front end of development as far as the tools that are available, so that we can really utilize them and bring them to the Zambian people. So welcome to this meeting. My role is very small. I may wear one hat or the other, but I'm still the same person. Okay, so welcome to all of you, and please take good note of what is being shared this morning. We are welcoming our speaker, Professor Steffen, just in a minute. I think the MC will do that. But I want to say welcome to this meeting, and already yesterday some meetings were happening. So we are very excited that you are here today in order to bring this, to us in great depths. So can I welcome you at this time, or is there anybody? Okay.
I took off my mask already, because talking with a mask is very difficult and you won't understand. Okay? I'm vaccinated 4 times, so don't be afraid of me.
It's not switched
on. Yeah. Good morning, ladies and gentlemen, Mr. Chancellor. Thank you very much for the invitation. I'm really feeling honored to give a presentation here at your Chreso University, and I have to say it's going to be difficult stuff. So the only way that you will profit from it is if you write down what you don't understand, and then in the question and answer section I will do my best to answer all your questions. Can we agree on that? Also, if I'm running too fast, sometimes my English is very quick and sometimes I'm very lost. So if there is anything you didn't understand, please interrupt me, because it's my task to present to you in a way that you can understand. Otherwise, this is not science. Good, so having said that, I sit down and then I would start my presentation. Why are we dealing with hypertension? Well, that's simply said, thank you very much. This is a very old study showing the relation between stroke mortality and the usual blood pressure in relation to the different age groups. You see here to the right, 80 to 89, 70 to 79, and so on. And on the left side is the systolic blood pressure, and on the right side, the diastolic blood pressure. And what you can easily identify is, say we go to the group of the 60 to 69-year-olds and look at the risk if someone has a blood pressure of 140 systolic, and compare him to someone who has a risk who has a blood pressure of 160, you can identify that the risk has doubled. So if you go through all these lines and look at all those age groups, it's always the same. A 20 millimeter difference in systolic blood pressure means the cardiovascular risk, in this case, stroke mortality, is doubled. And the same holds true on the right side for 10 millimeters of mercury in diastolic blood pressure. It's very easy. 20 millimeters is doubling the risk. So reducing 20 millimeters of mercury is reducing the risk nearly by half. We know now that's not quite 50%, but it's at least 40%, which can be reached by lowering blood pressure. I just showed you the relation for stroke mortality. Here's another disease, it's ischemic heart disease, but you see the relation stays the same. And one thing is very important, this relation goes down to values of, say, 115 over 75. Down to this value, there is no obvious stroke up in the lines, so that we could define, okay, from here on it's hypertension. That means every definition of hypertension is simply arbitrarily. If I would be a politician, I would say, I call hypertension 180 over 110. Why? Because there's only a small part of the population which would need treatment. The further down you go with your definition of hypertension, the larger the population at risk, meaning you have to invest more money to treat all those patients. So this is not a medical decision, it's a kind of political decision. And the decisions have been made by the European Society of Hypertension, as you can see in here. We talk about hypertension starting with a value from 140 over 90. The Americans, the American Heart Association and the American College of Cardiology in 2017 and decided, no, this is too high. We decide that blood pressure, hypertension starts at a value of 130 over 80. You see, all of a sudden, 17 million Americans have been called hypertensive simply because the definition was changed. And now we can continue the International Society of Hypertension, and that's a society where whole Africa relates to. They stay with 140 over 90. They did a simplification. They only got 4 grades. It's normal BP below 130 over 85. It's high normal BP, 130 to 139. Up to 89, and then grade 1 as the Europeans, 140 to 159 over 90 to 99, and then only one grade 2, meaning everybody who is above 160 to 100. So once again, the definition is arbitrarily. As well as the life years lost and the quality adjusted life years lost. One killer is high blood pressure, and number 1 in the disease-adjusted life years lost is hypertension. Following this is an offense. It's you that is taking in the exhaled smoke from the smoker, being exposed to the same risk as the smoker. So send them off. Smoking should take place only in open space. Now the next problem you see here is, are you familiar with the term prevalence? Do you know what that means? Prevalence is the percentage of a population at a given time having a disease. And here you can see hypertension prevalence across 33 African countries, ranging from, say, 15% up to 70%. Do you believe that? I do not. And one of the important things is, this is why there is a by people who are hypertensive, and it's very easy. You should sit for 5 minutes. then you should take 3 measurements, each 1 minute at least apart, and average the last 2 measurements. Then you are doing state-of-the-art, guideline-conform blood pressure measurement. Now go to your head and think about how we do the blood pressure measurements. I do not want to look into one's eyes, but I believe never that you do it the way I just talked about it. You don't have to tell me, but think about it, okay? So how we measure blood pressure is very important. And then there is one thing which is even more important. Prior to telling someone you are hypertensive, which gives him a stamp on his forehead, hypertension, you should be sure that the patient is suffering from hypertension. And what you can see here is a large study. Hypertensive patients at the first visit, 1,949 of the 8,247, means the rate was 12.8%. And then they came back to a second visit, and then it was only 10.5%. And those who were hypertensive at visit 1 and visit 2 were only 7.7%, nearly half the rate as on visit 1, meaning you need several measurements, at least 2 measurements on at least 2 different occasions before you can tell someone you are hypertensive. We have seen the same thing in our study done in Malawi at the Lighthouse. Here you see the values above 140/90 with 2 measurements on the first day of the study, and you see the numbers compared to the WHO STEPS trial in Malawi. And then if we continued and used at least 2 measurements on at least 2 occasions, a completely different picture came up. The rate of hypertension suddenly dropped enormously in each age group. So several measurements over time are needed. Having said that, this explains why all the guidelines think that, number 1, there should be an exact type of blood pressure measurement, as we just have said. And the recommendation is that out-of-office blood pressure measurements should be used. Now we are at a point, I have to say something, in a country like Zambia. We are talking about the transition from public health-oriented general medicine to an individualized approach. 24-hour blood pressure measurement will not help any society. It will help the individual. And one can say, of course, the more individuals you help, the more the society will profit. But it's different from going out to the villages, sitting down, measuring blood pressure in the population. The clinical indications for blood pressure, 24-hour blood measurement are listed here, and one may be important even in a country like Zambia, and that's the blood pressure control in pregnant women, because there are very interesting studies showing that pregnant women which have high blood pressure in pregnancy are prone to eclampsia. I'm sure you know that. And if they are controlled by using 24-hour blood pressure measurement, the rate of eclampsia is dramatically going down. Now, 24-hour blood pressure measurement, it's like that. As you can see, the man is smiling. So it's not dangerous, okay? You see it's the usual cuff fitted to the upper arm, and then he has a small machine wearing to his side where all the measurements are stored. These small computers are programmed to do blood pressure measurements over the day every 15 minutes and during the night every 30 minutes, and it's all stored in the small computer. And that's how it is looking. That's a 24-hour blood pressure profile of someone who has hypertension type 2, stage 2, and who is not treated. Down here is the heart rate, and then you can see the measurements over the day. Now, he obviously something had happened here because there's a sharp increase in blood pressure, and probably this was watching TV, a criminal thriller. So if you do 24-hour blood pressure measurement, it's very helpful if you give the patient a diary where he should write down things he did observe or experience, like heartache, like dizziness, something like that. Then what you can see already here, during the sleeping time, the blood pressure is going down. And then the next morning, getting up, the blood pressure is going high. Then he has run to the bus because he was late, the blood pressure is even higher. And then he met his boss, and that was very bad. Now, I'm joking, but you can see the blood pressure is not always on one number. It's changing all over the day. And what is important, it's also changing if you are doing an afternoon nap. You can see here, during the nap, the blood pressure is going down. Always the blood pressure is going down. Now, this is not to tell you that you talk to your boss and say, I have been at the presentation, they told me napping is lowering blood pressure, so I have to take nap. If you are napping the whole day, that's very bad, because then you are not doing exercise. That will increase your blood pressure. Okay, but what I want to point out is it's not the nighttime which is lowering the blood pressure, it's the sleeping or the resting time which is lowering the blood pressure. The normal values you have to remember when comparing clinic blood pressure measurement compared to home-based blood pressure measurements or 24-hour blood pressure measurements are different. We said 140/90 is the threshold of hypertension in the office. It's 135/85 for the daytime mean value, 120/70 for the nighttime mean value, and as you can see, nighttime is lower than daytime, so for the whole 24-hour period, it's 130/80, which is the threshold for hypertension. Now it's getting complicated. But you have to understand that, because otherwise you will miss the rest of my presentation. If we use office blood pressure measurement and use ABPM, 24-hour ABPM, we can differentiate 4 different groups. We said the value for the daytime mean is 135/85 in the ambulatory blood pressure measurement. And we have said 140/90 is the threshold for the office blood pressure measurements. Now we can say, okay, there is someone having normal office blood pressure, meaning below 140/90, and normal 24-hour blood pressure, meaning daytime below 135/85. Then we are down here, normal office BP and normal ABPM. And that would be either sustained normal tension, patient doesn't have hypertension, or if he is treated, that's where we want to have all our treated patients, because that would mean well-controlled hypertension. You understand that? Office normal, ABPM normal. Now the opposite would be exactly the blood pressure is high in the office, above 140/90, and it's also high in the 24-hour ambulatory blood pressure measurement, be over 135/85. So that means sustained hypertension in someone who has not been diagnosed, or if she or he is on treatment, uncontrolled hypertension. She may be taking blood pressure lowering drugs, but it's not working, or she is not taking it. Okay? And then there are 2 other groups where the blood pressure is normal in the office, but it's high during the 24-hour ambulatory blood pressure measurements. And that's a very difficult group to identify, because sitting in front of you, you think everything is fine, but it is not. This type is called masked hypertension. And the other one is the other way around. You have someone with high office blood pressure, but normal values out of office in the 24-hour blood pressure measurement. This is called white coat hypertension. If I'm looking around, you should, in Zambia, probably call it blue coat hypertension, because it relates to the fact that sitting in front of someone from the medical personnel increases your blood pressure. Okay? So probably the term for Zambia would be blue coat instead of white coat hypertension. Now this is white coat hypertension. You see, someone is coming to the office, blood pressure is high. Leaving the office, blood pressure is going down. Coming back the next morning, blood pressure is high. The physician sitting there, the clinician, the nurse sitting there thinks, okay, this is hypertension. It is not. It's white coat hypertension, and it affects 20 to 25% of all of those who sit in front of you and you think they are hypertensive. And this has consequences. If you prescribe antihypertensive therapy to these patients, they probably don't need it. Okay, and here's an example from someone who is treated already with 25 milligram of hydrochlorothiazide, and you can easily identify very high blood pressure when visiting the clinic, very high blood pressure when coming back. He is not controlled because his blood pressure is always high, but we call this white coat effect. It's true hypertension, and on top of true hypertension, he has additionally high blood pressure when he is in the office. So this is white coat effect, not white coat hypertension. Did you understand the differentiation? Okay. Next example, masked hypertension affects approximately 15%. So every 6th patient sitting in front of you, having normal blood pressure values, probably may suffer from masked hypertension. And this is something which is observed all over the world. It's not specific for the United States or Europe. As you can see here from a large study, looking at the data for Africa, 17% of patients in 24-hour ambulatory blood pressure measurements had masked hypertension in Africa. The study was predominantly done in South Africa, and around 5% only were found to have white coat hypertension in this specific study. Why I'm talking about that? These types of hypertension are not benign. As you can see here, in a way, you can measure the thickness of the carotid artery. Are you familiar with this system? Do you know that? If not, I explain it to you. It's very easily done. You take ultrasound, you have the carotid artery, and you can measure the thickness of the carotid vessel wall by using ultrasound. And there are normal values, and then you know whether it's above or below or normal. If it's above, especially if there is plaques to be identified, then you know this patient has already ongoing atherosclerosis. So having used these measurements and comparing that to normal tension, you can see those with sustained hypertension have a clear increase in this intima media thickness of the carotid artery, and those with masked hypertension are in between. They are not normal, they are not as bad as those with sustained hypertension, but they are in between. So it means there is already ongoing damage done to the vessels, okay? And if you look at white coat hypertension, there's a similar thing. This is left ventricular muscle mass. We relate only to that, and you see again, this is normal tension, this is sustained hypertension, and white coat hypertension is in between. So even these types, these phenotypes of high blood pressure, of hypertension are not benign. Meta-analysis showing that office hypertension compared to normal tension, so white coat hypertension compared to normal tension, has an increased risk for cardiovascular events, for cardiovascular deaths, and not for total deaths, but for cardiovascular deaths and cardiovascular events, the risk is increased. Looking at a Finnish study done in Finland, patients were observed for 8 years, and it was looked the event-free survival depending on the blood pressure category: normal tension, white coat hypertension, masked hypertension, sustained hypertension. And you see after 8 years, those with sustained hypertension, roughly 83% were surviving, the other way around, 17% were dead. For those with masked hypertension, the numbers are a little bit better. It's around 88% surviving, the other way around, 12% were dead. For those with white coat hypertension, it's similar to those with normal tension, surviving around 95 to 96%. So the difference in survival, and this during the night or during the sleeping was absolutely non-controlled. This type of treating may be even dangerous because, as you can see, for instance, here, if the blood pressure falls all of a sudden, there's only one chance the body can react, and that is an increase in heart rate. Increase in heart rate in someone who already is suffering from ischemic heart disease may lead to myocardial infarction. And indeed, there have been cases published with myocardial infarction following unretarded, unextended release nifedipine. So if you have the chance to use another preparation, then it should, another type of calcium channel blocker, then it should always be another type of calcium channel blocker, like amlodipine, for instance, which has a slow onset of action, or at least, if it is nifedipine, then it should be the extended release version. Here is something else which is very interesting. The patient has an increase in blood pressure during the night. And this patient is a snorer. And there is a disease called obstructive sleep apnea. Have you heard of it? It's kind of suffocating the patient. He is sleeping, laying back, and the tongue is falling back. And this obstructs the airway. And this is a kind of very, very intensive sympathetic stress. So if someone is suffering from this syndrome, he will be suffocating several times every 2 minutes during the night. And you can imagine that will give every time an enormous sympathetic drive leading to high blood pressure, okay? So increase in blood pressure during the night in someone who is snoring gives you 95% confidence that you have someone who is suffering from sleep apnea syndrome. Now, the disturbed variation in blood pressure is very important because it's associated with an increased cardiovascular risk. If the blood pressure is not falling during the night, that's not good. And it's very important that the increase in blood pressure during the night is not only pointing to obstructive sleep apnea syndrome, but also is an increased general cardiovascular risk. You see here the meta-analysis. By the way, you know how to interpret meta-analysis, or shall I explain it? Just a quick answer. Who knows what I'm talking about? Everybody is looking, nobody is daring to hear. Okay, now here you see the studies which have been analyzed, and this is the outcome within each of these studies. And then they are put together mathematically. And if there would be no difference in this case between nocturnal blood pressure fall, yes or no, then all the results should be on this line of identity, the 1. Everything is to the right or everything to the left is obviously different from 1. So in this case, the systolic night-to-day ratio, if this systolic night-to-day ratio was high, meaning there was no fall in blood pressure, the risk for this patient was 1.20, meaning 1.2 times higher than in those who had a decrease in blood pressure, or 20% increase. And the same is true non-dipping pattern, 50% increase in cardiovascular risk. The most important predictor for cardiovascular disease is indeed blood pressure measured during the night. You see here, systolic blood pressure, if it is increasing, of course, also the clinic blood pressure measurements tell you that there is an increase from, say, 0 to 1.5 if the blood pressure is increased. But the steepest increase, that means the best prediction is nighttime. If you look here, someone with 170 blood pressure measured in the clinic would have a risk roughly 1.25 compared to those who have normal blood pressure. But 170 measured during the night gives you more than doubling the risk of someone who is suffering from this type of hypertension. So it gives you an enormous amount of information about the risk. We have done studies in Malawi with our 24-hour blood pressure measurement program. What found we? 18.8% of the people living with HIV had white coat hypertension, 30%, 32% were suffering from mast hypertension. Mast hypertension was found as well as in those already on antihypertensive treatment and in those not on antihypertensive treatment. Same is true for white coat hypertension. And where do you look for it? Mast hypertension can especially be found in those with high normal blood pressure in the office, and vice versa. White coat hypertension is very often to be found in those who suffer from grade 1 hypertension in the office. And what is it all about? Now here you can see mast hypertension was associated with a reduction in glomerular filtration rate, meaning there is incipient renal damage in patients sitting in front of you having normal blood pressure values. This is difficult to identify if you do not use 24-hour blood pressure measurements. And the dipping pattern was only normal in 1/3 of the patients, or the other way around, 2/3 of people living with HIV had abnormal dipping patterns. Okay, and this is an example where you can also use 24-hour blood pressure measurement. I must say that's the most impressive patient I ever have seen. There's a 56-year-old woman with known hypertension, and she is on hydrochlorothiazide 25 milligram, enalapril 20 milligram, amlodipine 10 milligram, atenolol 100 milligram, all once daily. She comes to the clinic with severe hypertension, 247/117. And the clinician said, no, I can't send her home. He convinced her to go to the ward. She went to the ward, and here she received hydralazine IV. You can see it here. The blood pressure went down, And the next morning, the blood pressure was rather normal, and this patient said, no, I don't want to go, don't want to stay, I go home. And she went home. And I'm sure, probably for the first time in her life, she has taken her tablets at that morning, because here the blood pressure is much lower than when she were at the hospital, at the outpatient department. So you could use 24-hour ABPM to check for the adherence of your patient. Okay? Good. Now, the next part of my presentation would be arterial stiffness and pulse wave analysis. Before I start there, any questions? Okay, if the question, they're in the back.
Nighttime BP, when it's high at night, the cardiovascular risk increases during the nighttime. Should we now, is it recommended that we start advising our clients to start taking their increases when someone is sleeping? Should we advise them to take it at night so that we have much effect?
If you do not know the nighttime blood pressure of your patient and you erroneously think he should start taking tablets in the evening, you might lower his blood pressure during the night so far if you know the blood pressure is during the night. So that would be someone where you should have 24-hour ABPM before deciding on that. And I'm talking about those drugs which should be given once daily. If you give dosage 2 times a day because the half time is only 8 hours, then it's okay. But do not give additional doses in the evening without knowing the blood pressure of the patient during the night. Maybe dangerous.
I wanted to empty the blood. So I just wanted to know what is the main
drive. So it increases blood pressure. This is the reason why the bladder should be emptied. You were talking about the furosemide. Furosemide is a very bad antihypertensive drug. Why? It's very effective diuretic, and you need it in heart failure, and you need it in renal failure. But if you give furosemide to someone to control blood pressure, the thing which will happen is he is going to pee a lot, but in the following hours, the body will retain all the fluid. So it's out and in, out and in. This has nothing to do with blood pressure. Furosemide should be reserved for those who have heart failure, who need uncomplicated hypertension. In these cases, hydrochlorothiazide is much more effective in lowering blood pressure than furosemide. Okay, looking on the clock, we have to continue. I'm sure you are familiar with the observation that the typical blood pressure in elderly patients is systolic is high, diastolic is low. I was asked yesterday already this question. So we call this isolated systolic hypertension. And you can see in blue the rate of isolated systolic hypertension is increasing with increasing age. Why is that? Now a little bit of physiology. When the heart is pumping, the moment the aortic valve is opening, there is the stroke volume of the left ventricle is propulsed. It's thrown out of the left ventricle, going into the aorta. And then this means as long as the aorta is elastic, this means the energy is then used to dilate the aorta like a rubber band. In the moment when the aortic valve is closed, this stored energy, like in a rubber band, is used to propulse the blood flow to the periphery. You understand that? One could say that the elastic aorta is, so to say, our second heart. The first heart is pumping, and the second heart is propulsing the pulse wave. Did I understand? Did you understand? Okay, this phenomenon is in German called Windkessel, in English it's air vessel, and it's meaning that as long as you have an elastic aorta, the blood flow to the periphery is undisturbed. And I will show you what that means in this example. Here you can see a rigid tube. You hear it and you see it. It's a stiff vessel, and there is not a continuous flow, in contrast to this elastic vessel, where there is a balloon dilating, and then there is a more continuous flow of water in this case. And that's the same in our body. When the vessels are stiff, like in this example, it's going like that. It's not a continuous flow. And if the vessel is compliant, it's elastic, then we have this type of flow. Did you understand that? Probably from looking to the picture is more easy to understand than by explaining. And the problem then is the reduction of systolic blood pressure in old arteries with increased stiffness. What we just saw means the following. The blood is coming out of the left ventricle, going down to the periphery. And then there is a reflection. I'm sure you have already seen, if you throw a stone into a basin, what will happen is there are small waves, right? Running over the surface of the basin, right? And if there by chance should be a wall, the wave will hit the wall, and what happens then? What happens if the wave hits the wall? It comes back. Did you observe that already? Yeah. The wave is coming back, and then the ongoing wave and the backward wave are meeting each other, meaning that all of a sudden the wave is increased. Did you ever observe that? If not, go to a pond and throw a stone into it. Okay, then you will see. And the same happens in our body. The wave is coming out of the heart, and then there is reflection at the bifurcation of the aorta, meaning that from there is a backward wave, the same as on the water surface. And that means then the forward wave and the reflected wave are superimposed on each other, finally giving this type of pulse wave. Now, in younger patients, where the aorta is still elastic, it's looking like that. In older patients, those who have already stiff vessels, the velocity of going forward but also coming backward is increased. So the reflected pulse wave and the ongoing pulse wave end up in a much higher systolic blood pressure related to this faster forward and backward flow of the blood. That means there is a difference in central blood pressure, that's the blood pressure measured over here, between older patients, where the pulse wave comes back very fast, very quick, compared to younger patients, although the blood pressure measured at the upper arm circumference is absolutely identical. The only difference being what is going on in the aorta. Is it stiff or not? Having the same blood pressure at your upper arm may probably mean there is a large difference in the central part of the aorta. This is the same what we just saw. Now, you can measure these things, you can analyze it, that's called pulse wave analysis. This is someone where everything is normal, and this is someone where there is increased peripheral resistance, meaning stiffness. And you see this part from here to there is superimposed on top of the normal pulse wave, leading to high blood pressure. Now, with the modern machines, one can measure that. You can see here, systolic blood pressure peripheral, 117/80, central blood pressure, 108. So this blood pressure is, as it should be, centrally lower than peripheral in the periphery. So one can translate that for the patient into smileys. Smileys are international. Even in sub-Saharan Africa, everybody will understand the smiling smiley. Don't you think so? Because you are smiling. Okay, that's the idea behind this machine. Translate complicated physiological contents into easy languages to make it understandable for the patient. Here's another example. This was a 60-year-old man, and you can see the difference. The pulse wave was higher, the other measurement was higher. It's still good enough to say it's the same as your age. And this one was 69-year-old. And you can see the pulse wave was too high, and the vessels are, so to say, older than his age has been. And this translates into there is already ongoing atherosclerosis. Once again, a very important measure you can do to analyze the effectiveness of your blood pressure lowering treatment, you can see here from one patient. First, this patient was on a treatment consisting the peripheral blood higher than the peripheral blood pressure measured. The patient came back, and then the peripheral blood pressure was still 163 over 103, so not much changed compared to the other treatment, but the central blood pressure had gone down to 152. So 20 millimeter lower central blood pressure simply by changing drug treatment with using the right drug treatment. There have been studies. A very important one is the CAFE study, which proved that what I was saying is right. The CAFE study compared amlodipine perindopril, so ACE inhibition with calcium channel blocker, versus atenolol plus benrofluazide, that is beta blocker plus hydrochlorothiazide. What you can see is the outcome, stroke events in this case. These ones were the ones treated with benazepril and perindopril and amlodipine, and these were the ones treated with hydrochlorothiazide and atenolol. And you see the risk reduction was 23%. Those treated with perindopril and amlodipine had 23% less stroke compared to those treated with atenolol and thiazide diuretic. And why was it? The peripheral blood pressure was nearly identical, but those treated with amlodipine and perindopril had the lower blood pressure at the central part of the body. This easily can explain why that happened. And we know from the Framingham Heart study that the pulse wave, which is a measurement for the stiffness of the aorta, really gives you a better prediction of the cumulative cardiovascular event rate within the next 8 years. If it's above 11.8, then you have a high rate of cardiovascular events. And looking at clinical events overall, you can say if there is an increase of 1 meter per second compared to those who have normal pulse wave velocity, there is a roughly 14% increase in total cardiovascular events, a 15% increase in cardiovascular mortality, and a 15% increase in all-cause mortality. So knowing your pulse wave velocity gives you a risk estimate. And that's why already since 2005 there's an ongoing discussion that indeed the pulse wave velocity as well as the central hemodynamics I was talking about may be included into the risk stratification of patients with hypertension. And I'm sure that the upcoming next year that will be in upcoming guidelines of the European Society of Hypertension will include one or the other way to test for these things I just presented to you. And with that, I do thank you for your attention. Thank you very much. It was my pleasure. I'm in time because you stole 15. Good. So I get absolution. I didn't talk about smoking as a risk factor. Shall I do it? Yeah. Who of you is smoking? Shall I vent them out and then you raise your hand? No, there is no question about it. As I already showed you, smoking is, I should put on my mask if I'm walking around. Smoking is the number 2. Okay, good. First questions, then smoking.
Thank you, Prof, for the good presentation. You have reminded us about hypertension. Before I speak of the smoking, I think the VC should have told you that there are 2 types of smoking here, cigarette and cannabis. So I don't know which one he wants. So
the advantage of cannabis, you also can eat it as cake.
So, Prof, I've followed your presentation very well. I I've just got a contribution. The first thing is the availability of these machines. How are they available today in Zambia or at Chreso University or clinic? Because for me, I think, coupled with the question asked by Mapiki, whether we can advise our patient to be taken in the night, I would wish to know the dipping status of our Zambian population. Therefore, for MPH or whatever studies, postgraduate, let's look at the prevalence of dipping or non-dippers in the Zambian population. Thereafter, we can encourage our patients whether to take at bedtime or to take in the morning. I've read studies done in Nigeria on Nigerians where they even recommended the diuretic to be taken at bedtime with very good outcome. I did a similar study because when taking diuretics, I was worried of the sleep pattern. However, the sleep pattern was not disturbed after 12 weeks, even if you take in the evening. So mainly my concern is a follow-up study. Can those machines be available? We do a study within Zambia and know the dipping status of our people. Thank you.
Number one for your comment is I wouldn't take a diuretic in the evening. Me, myself, I wouldn't do that. Taking a diuretic in the evening means your sleep must be disturbed. So probably you said there was no difference prior and after taking the diuretic in the evening is because they went to the toilet, so the blood pressure was high. So be careful with diuretic in the evening. It's not number one choice. Now, with respect to your question, are these machines available? I brought two, and they are available at the Chreso University. I trained 4 of the co-workers of Chreso University, and they know how to do it. It's not only for 24-hour ABPM, it's also an inbuilt capacity to do pulse wave analysis. So it's available right now.
It was a very nice presentation.
Thank you.
But my question is a little away from your presentation because I need to know this answer from you. We are skipping food like morning or in the night. So what happened? What is the linkage between skipping food and increase in blood pressure?
Increasing food? Did I understand
no,
right?
Skipping food intake. Skipping our dinner or breakfast and how it links with increasing in blood pressure.
Okay.
Thank you, Prof.
If you do not eat, your blood pressure will go down. If you do not eat, you will die. So I understand there's a lot you can do with the way. If you reduce your salt intake, your blood pressure will go down. Number 2, vegetarian diets are blood pressure lowering. Number 3, if you eat a diet rich in vegetables, fruits, and low-fat dairy products, your blood pressure will go down. If you reduce your fat intake, your blood pressure will go down. If you abstain from drinking Coca-Cola and other fructose-containing drinkings, which are now sold all over the world, your blood pressure will go down. So what I'm trying, if you reduce your body weight, your blood pressure will go down. Look at me. I mean, no, you should look at me because I have this problem, and I know this time what I'm talking about. It is very, very difficult to reduce body weight. I have reduced 20 kilo, so I'm knowing what I'm talking about. It's a constant war against yourself. It's the only way you can do it. There is no magic bullet coming from above telling you now your body weight is going down. You have to abstain from eating. That's the only way it is working. And then you can use tricks, of course. You should abstain not in the beginning from those things you like the most. Okay, then you will not stay long enough to reduce body weight. But what I'm going to say is it needs a lot of understanding and, of course, a lot of motivation. It's a lot of motivation necessary to increase exercise, what I did, to reduce intake in total of calories and to increase the intake of fiber, of whole grain products and all those things. Did that answer your question?
Thank you very much for that. Thank you very much for the presentation, really informative. I would like to find out, I had my late dad also was hypertensive. So there is actually a pattern that, okay, he used to take medication for it. I'm not too sure what medication, but there's a point which he started taking alkaline water, and it seemed to kind of control, you know, those times when he would have it so severe. So I would like to know what the relationship is between, or how taking alkaline water influences.
What's this type of water?
Alkaline.
Alkaline water, okay.
Yes. Sorry, secondly, also if there's been any studies that show perhaps the difference between maybe a wrist machine for measuring blood pressure as compared to the one that you have on your bicep.
Yeah, I'm not aware of large-scale studies showing that drinking a lot of alkaline water will help. I'm not aware of it. I could imagine that there is a certain effect, but I won't believe that it is the same effect as with diets. I would doubt that. Now, for your question related to wrist measurement or upper arm measurement, the problem is the measurement has always to keep in mind the height of the heart, which is very easy. If you are measuring at the upper arm, it's automatically on the height of the arm, of the heart. If you are measuring at minimum, you must say is you have to keep your arm with the wrist measurement device kept at heart height. And then you can see there's a problem. I have to bend my arm. So nobody knows exactly what is happening in the blood vessels here if there is bending. So the best way would be to support your arm at that height, and that is a little bit difficult. And in addition, the measurements are not, where should I stay without, now here. The measurements are not as exact as those done here. So the recommendation nowadays is wrist measurement devices should only be used in those where they have upper arms, where there no cuff measurement is available, because there is an upper limit of size for cuffs. And in these patients, the recommendation is to use wrist measurement machines. Question? No. Then there was the question of smoking. Yes, what shall I say? Smoking is deadly. I'm joking. It's clear what from the, I think it was the second or third, and the most important factor for disease-adjusted life years lost. So there is no question, there is nothing healthy in smoking. So an advice for someone who has already one cardiovascular risk factor like hypertension should always include stop smoking. Now, being an old physician, I have to say, if it doesn't make a difference, if someone is sitting in front of you, diagnosed with hypertension for the first time, and you should stop smoking, what do you say? In one step.
Thank you very much, Professor. Well, my question is it just the smoke or maybe content of the cigarette which affects the system, or rather the blood flow or the blood pressure?
In a cigarette?
That's where my question lies. Is it the smoke? Because people may see it to be like, maybe it's just the smoke, minus knowing that in the cigarette there is that content of nicotine, and which can cause the blood to go up, like the blood pressure to go up. So maybe you might find that even in caffeine. So intake, like, can it be the same, or maybe it's quite different from?
That the absolute amount is different. If you smoke and stay with you, but in the side smoke, which are you inhaling when sitting beside someone, are all the toxic substances induced by inhaling all the time secondhand smoke. Okay? And the blood pressure effect of smoking in someone who is used to smoke is very low. It's increasing the sympathetic nervous activity, and if you are used to smoking, the blood pressure increasing effect of smoking is low. And that's comparable to coffee drinking. If it's not more than, say, 6 cups per day, then coffee is very healthy. It reduces the rate of chronic liver disease, it reduces the rate of hepatocellular carcinoma, and at the same time, it does not increase blood pressure, it does not increase any kind of arrhythmia. So up to 6 cups of coffee per day is really healthy, or can be considered as healthy, I should say, in this way. That's different from smoking. There's nothing like a recommendation to smoke 6 cigarettes on a day.
We have members of the press that joined us a little bit late. We can take advantage of the 15 minutes to interact with the professor. The Vice Chancellor is also in our presence, and Pastor Reuter is also in our midst. And the marketing team can. Dr. Florian is going to talk about, to kindly proceed to the